Hi, Facebook. This is Dr. George. This is Chris George. I'm a medical oncologist at Delnor Hospital, and we put together a program today to talk about prostate cancer. Not sure how many people are out there watching, but if you have questions at any time while we're talking, please email them or put them in the comments section of Facebook, and we can try to address them in real time. So this is a very general talk, informational about prostate cancer. I'm going to talk a little bit about what I would consider to be localized disease. That's cancer limited to the prostate gland where we think it's curable. That's generally a stage where we're thinking about surgery, robotics, proton center, seeds, different forms of radiation therapy, and we'll talk a little bit about that. Then we're going to talk a little bit about advanced disease, so cancer that has spread beyond the prostate, sometimes to lymph nodes, sometimes to the bones. We're very good at treating that. We have excellent treatments, and there's been a lot of advances, and we can talk about that as well. And then kind of wrapping up, I'll talk about supportive care. So during prostate cancer treatment and the patient's journey, bad things can happen. You can have treatment-related effects on the heart or the bones, and I want to address kind of what we do to keep patients otherwise healthy. The title of the talk is Not Your Father's Prostate Cancer, and the reason we titled it that way is really talking about things that have changed. So I'm in my 50s, and my father, if he had prostate cancer, would have been diagnosed probably in the 1970s, and the way we treated prostate cancer in the 70s and 80s really has very little to do with how we treat it now. So I want to highlight some of the changes and advances that have happened. So kicking off, localized therapy. People who are watching probably know what a PSA is and how that blood test oftentimes can bring prostate cancer to light. When that happens, we want to find out how far it has spread, and hopefully when we find it, it is limited to the prostate gland. And we like that because at that stage the cancer is curable. We think we can cure the cancer. The way we cure prostate cancer that's limited to the prostate gland, really two major ways, two major buckets. One is surgery and one is radiation. And there's different kinds of radiation and there's different surgical techniques, and I'll talk a little bit about that. But I guess in the spirit of Not Your Father's Prostate Cancer, I wanted to talk more about not treating the prostate cancer, which I think has been a major, major advance in the last 10 years, something we call active surveillance. And let me talk about active surveillance a little bit. What we know about prostate cancer is that some of the disease, some of that group of patients who have metastatic or localized prostate cancer, sometimes it's very aggressive and becomes life-threatening. But some cases of prostate cancer don't. Many of you may have heard that if you look at men in their 80s or 90s, a very high percentage of them have prostate cancer. And among that group, elderly men, if you don't treat that prostate cancer, most of them probably will die of something else. So how can we decide which patients need treatment for prostate cancer and which patients don't? And that's where we talk about active surveillance. By looking at the PSA, by looking at the characteristics of the cancer, how aggressive it looks under a microscope, something we call the Gleason score sometimes, we can get a sense of how aggressively that cancer is going to behave. And if we have a feeling, or if we can predict that it's not going to behave aggressively, some of these men don't need surgery and they don't need radiation therapy. You can watch the cancer. And the reason we call this active surveillance is because this isn't a situation where the doctor will shake this man's hand and say, goodbye, you don't need treatment. This is a situation where we really need to watch the patient closely. We need to see what the PSA does. The patients need a physical exam regularly, sometimes a repeat MRI, and sometimes a repeat biopsy. And by doing that, by following the patient over time and looking at these tests, we can decide when and if they ever will need treatment. And some of these men will be spared treatment entirely. To me, the greater utilization of active surveillance for localized prostate cancer has been a major advance in the last 10 years, because what it does is it spares these men the toxicity of cancer treatment. So by watching them, by not giving them radiation, they're not going to have the sexual dysfunction, they're not going to have the incontinence, the rectal dysfunction that we see sometimes with prostate cancer treatment. And if we can be more targeted and more specific about who gets radiation and who gets surgery, we can avoid these toxicities, men who have localized prostate cancer. Again, I'll pause briefly. If anyone has any questions, I would love to hear them as I'm talking. And there's a group of people behind the camera who can relate the questions to me as they come through. Talking about patients who we think do have aggressive cancer that does require treatment, again, generally speaking, that falls into two buckets. One is surgery and one is radiation. Talking about surgery first, there's different techniques. There's open prostatectomies and there's robotic prostatectomies. What I think patients are finding after they're diagnosed and after they start looking into surgery, most of our surgeons these days are trained on the robot. I think that's the trend, and that's what you're going to see in most contemporary surgeons. There still are some outstanding surgeons in Chicago, in the Chicagoland area, people whose names you probably know, who don't use the robot, and I think that's perfectly acceptable. I would say when you are trying to decide about surgery for prostate cancer, I think you're choosing the surgeon, you're not choosing the technique. I would say, to me, the robot is not an equalizer. If you have an outstanding surgeon who doesn't use the robot, that's better than a mediocre surgeon who does use the robot. And that's my spiel on surgery, and I don't want to get myself in trouble, so I don't say much more about that. Radiation, and I know I got some questions that I'll come back to before the talk about different kinds of radiation. There's many different ways to deliver radiation to the prostate glands. There's external beam where they shine the radiation into the body, delivering a high dose to the prostate gland where the tumor is specifically. They can implant radioactive seeds. That's called brachytherapy. I'm sure some people have heard of that. And they implant them actually into the tissue of the prostate and deliver radiation that way. And then there's a new kind of radiation, proton beam radiation, that maybe you guys have seen driving around the Warrenville area. There's a proton center there. I think all of those techniques have their place. I think all of them have been proven to be effective. I think in terms of toxicity, there's some differences, but I think maybe they're more alike than different. If our goal is to cure the prostate cancer, all of them can be effective in that mission. I find I get a lot of questions about proton beam radiation, probably more than any other type of radiation therapy, and I'll tell you what I tell people about that. It's a little bit newer, so it doesn't have the track record that some of the other techniques do. I don't think there's any reason to think that proton beam cures less people than conventional radiation therapy. I think proton beam, from everything that's been published, I think we can say with pretty good confidence that it's just as good as any other technique in curing the prostate cancer. I think the potential advantage of proton beam has to do with toxicity, in that the radiation can be delivered at a higher dose to the cancer cells themselves and spare normal tissue, and there is reason to think that it might be less toxic. There is evidence that suggests that. Whether or not you are convinced by the available evidence or whether you want to see more studies, that's really an area of controversy, I would say, in the prostate cancer world. I like working where I work because we have all the techniques available. Patients can see a radiation oncologist at my facility and get an opinion about proton beam and conventional beam radiation therapy, and really ask specific questions about the individual case and decide what's best for that specific patient. So that's one advantage of working where I work. So I'm going to leave localized disease now and talk a little bit more about advanced disease, and that's more what I do in my day-to-day practice seeing prostate cancer patients. I'd say most of the patients that I see with prostate cancer, the disease has spread beyond the prostate. So we'll see it either in lymph nodes. Statistically, it goes to bone with some frequency. And we don't like it when that happens. That's harder to treat, but we have very effective treatments, and we've made a lot of advances in the past 10 years, and I'll try to highlight some of those. So I'd say the backbone, the mainstay of treating prostate cancer beyond the prostate is manipulating a man's hormones. And what we know about prostate cancer cells, if you take the tumor cells and you put them in a petri dish or a test tube, those cells won't grow unless they're exposed to testosterone. And if we take testosterone away, those cells, some of them will stop growing and some of them will die. So that's what happens in the lab in a test tube. We can actually do that in men. We can take their testosterone level and bring it from a normal level down to a suppressed level, and the same thing will happen in a man's body. Prostate cancer cells will stop growing and some of them will die. And when we do this, that's when sometimes we'll see the scans look better, patients' symptoms get better, and the PSA will drop. Back when our fathers were treated for prostate cancer, the way we did that was with an operation called an orchiectomy, which is surgical removal of a man's testicles. That's very effective in terms of lowering the testosterone, and it was very effective in treating the cancer. But for reasons that I think are sort of self-evident, that's not super popular among men. They prefer not to have that done. So now we have new drugs and treatments that can lower testosterone without that surgery. I will pause and say that orchiectomy, that surgical removal of the testicles, still has a place and we still use it, but most men don't choose that option. They choose to have pharmacologic maneuvers that lower your testosterone. Most of the time that's an injection. An injection you get every month or every 3 months or every 4 months, depending on what preparation you get. These injections, sometimes we call the injection hormone therapy. That's really not being very precise with our words. It's manipulating the hormone climate of a man's body. So it's a hormonal manipulation. We're not injecting hormones into your body. But that injection suppresses testosterone. Testosterone goes from a normal level down to a suppressed level, and the effects in terms of cancer control can be remarkable. It can keep the PSA low, keep the cancer from spreading, keep a patient from having cancer-related symptoms for months and sometimes years, sometimes longer. We call that castrate-sensitive disease. Sometimes we call that testosterone or hormone-sensitive disease. So that's a point in a prostate cancer patient's journey when the disease still responds to these hormones. What we've learned really in the last 5 or 10 years is that we can control the cancer longer if we're a bit more aggressive. So I told you, historically, the mainstay was this surgery, removing the testicles. Now we have these injections that lower testosterone. And really in the last 5 or 10 years, we have new drugs, some of them are pills, that additionally block the interaction of testosterone and cancer cells. And adding these pills, you might have heard of some of these drugs, enzalutamide, abiraterone, also called Xtandi, Zytiga. If we add these drugs to the injections, we can get longer, more durable control. In other words, these men can stay in remission longer. And that translates into longer survival. People can live with their disease, even if we can't cure it, they can live with their disease longer and longer. We call that dose intensification sometimes. It's not right for everybody, but for all men who have cancer that's spread beyond the prostate who are on the injections, that's something that you should talk to your doctor about for sure. Really in the last year, and this is kind of exciting, this is breaking news, I think in the next 5 years, it's possible that we'll be treating men with hormones that's all pills. They won't need to come in for the injections. A study was recently published where they compared injections to pills entirely, and the men on the pills did just as well. And in fact, they seem to have less toxicity, which is really exciting. If we can deliver this level of cancer control while giving men less problems from the cancer treatment, you know, that's a home run. And if we can do it in a cost-effective way, that's really, really wonderful. Some other advances I want to touch on that maybe you guys have heard of. Targeted therapy. Targeted therapy is when we look at an individual's cancer. We look at the DNA, we look at the proteins that are expressed on the cancer cells, and we can look at, instead of prostate cancer painted with a broad brush where we treat everybody in a similar way, hormones, we treat each patient's unique cancer in a unique way. So that's where we talk about targeted therapy. And I think every patient with prostate cancer that's spread beyond the prostate should have a DNA analysis of both the DNA they were born with and the DNA in the cancer to see if there are any targets that we can use with medicines to treat that specific cancer. There are drugs called PARP inhibitors, and I'm trying to steer away from a lot of jargon in this talk. But about 10 or 20% of men can be treated with these drugs. That's where we need to look specifically to see if those targets are on an individual's cancer. I think that's super important. I think that any reputable cancer clinic in this day and age should be looking for those targets. And it really gets away from the concept that we can treat everybody the same, that we just look up in a cookbook on how to treat prostate cancer. What we do is we look at each unique cancer, each unique tumor, and see which way we can most effectively treat and kill those cancer cells. And that's kind of a brief introduction to targeted therapy. Immunotherapy has a role in the treatment of prostate cancer. If you've looked at any magazine or media outlet or social media in the last few years, you've seen something about immunotherapy where we can take a person's immune system and harness it and direct it to kill the cancer cells. That approach has been enormously effective in some cancers like lung cancer, bladder cancer, kidney cancer, melanoma, which is a skin cancer. I'd say prostate cancer in terms of immunotherapy is lagging behind a bit, but there's a lot of research going on to figure out why immunotherapy is not quite as effective in prostate cancer and to make it effective, to find new ways of delivering immunotherapy so that we more effectively kill the cancer. There is a treatment called Sipuleucel T, again, I don't want to give a lot of jargon, also called Provenge, where they can take serum from a patient and construct a vaccine that harnesses the immune system and tells the immune system to attack the prostate cancer. This is maybe the only cancer treatment that I can think of that is effective in extending a man's life, so helping somebody live longer with their cancer without doing much of anything else. So these vaccines don't lower the PSA, they don't make the scans look better, they don't produce any other effects that we can see that there's anti-cancer effects, but men who get this vaccine do live longer. I'd say it's not appropriate for everybody. It definitely has a role in men with slowly growing disease that's not doing much, that doesn't require more aggressive therapies, and it's something to talk to your doctor about. Switching gears, radiation therapy. So I talked earlier in the talk about radiation therapy to the prostate gland. Radiation can be delivered elsewhere in the body to other organs to control cancer. When prostate cancer has spread to the bones, sometimes it can produce pain, sometimes it can cause a fracture or an impending fracture, and radiation can be enormously effective in helping men feel better and stay fracture-free. So we use radiation in that regard all the time. What is new that our fathers didn't have access to is now we can actually inject radiation into the bloodstream, and that radiation can find the cancer cells, bind to it, release the radiation to that specific area, and treat the prostate cancer that way. There is a radioactive agent called radium-223, also called Xofigo, and for men who have cancer in the bones, what that drug is a targeted antibody with a radioactive particle that's bound to it. And when you put that in the bloodstream, that particle seeks out prostate cancer cells, finds them, and releases the radiation. It's really pretty amazing science that they were able to construct a molecule that could do this. And we found that it can be very effective controlling the prostate cancer. It definitely has a role for men whose prostate cancer is only in their bones. It's not as effective when the cancer is in other organs, and we don't use it quite as much. Talking a little bit more about systemic therapy, the topic that no one wants to talk about, the C word, which is chemotherapy. Chemotherapy has more toxicity than some of the other drugs that I've talked about. Can lower your blood counts, can make you feel tired. Sometimes you can lose your hair. So we don't use chemotherapy early in the disease very often, but when we really need to get control of the disease, it can be very, very effective. And I'm glad we have chemotherapy for prostate cancer. I have many, many patients who benefit from chemotherapy. When I was a younger doctor, we didn't think chemotherapy worked because the trials weren't showing benefit. But in the last 10, 20 years, some really informative trials have shown a lot of benefit with chemotherapy, and it really helps a lot of people. I find my patients to be fearful about chemotherapy, afraid that their quality of life is going to be sacrificed in the service of lowering the PSA, and I think those fears are legitimate and should be addressed. But I wouldn't want any patient whose disease is not well controlled to discount the possibility of using chemotherapy. I think it can be really beneficial, and in many, many cases, quality of life can most definitely be preserved. So I've alluded to this with some of the treatments that we've talked about, that we worry about cancer adversely affecting your body, but we also worry about cancer treatment adversely affecting your body. Two ways that prostate cancer treatment can harm a man, among others. One is the bones. So when we talk about testosterone and lowering testosterone, there's some good things about that, like the PSA goes down, like the cancer is controlled, but there's some bad things too. Your bones like testosterone. The testosterone makes the bones stronger, and if we take it away, the bones can get weaker and we can increase the risk of fractures. So it's very important, and this is something that I hope my patients hold me accountable for me to look at their bones and see how they're doing. Every man, whether you have prostate cancer or not, can benefit from exercise, weight-bearing exercise in particular, to strengthen the bones. Some men could use calcium or vitamin D supplements to strengthen the bones. In prostate cancer patients, this is doubly important, and in those that are getting hormone therapy that lowers the testosterone, it is much more important. So I think it behooves every patient to have that discussion with their doctor. We should check. We should run tests to see how strong the bones are and talk about any way that we can make the bones stronger. If not through exercise and vitamin supplements, there are medicines that can do that as well, and they definitely have a role. I also want to touch on cardiac toxicity. I think, unlike our fathers, there's increased recognition that men who are undergoing treatment for prostate cancer can have difficulty with their heart. We see more heart attacks and more heart disease in prostate cancer patients getting treatment than we do in those who don't. There's a lot to say about that, but we should be cautious in men who have pre-existing heart disease. And among this demographic who has prostate cancer, men in their 60s, 70s, and 80s, many of them will have heart disease, and we need to be mindful of that and work with the cardiologist to make sure that their medical management is optimized. I also think it is increasingly important for us to address cardiac complications of our treatment and cardiac risk factors. So if you're a diabetic, if you're overweight, if you have high cholesterol or high blood pressure, it's really important that we address those things and optimize that to the best of our ability to decrease the risk of heart disease as much as we possibly can. So I will pause there for a minute. If there's any questions, anything come in while I've been...
Larry is asking, with his father passing away at the age of 80 from prostate cancer, what can he do with his physician to manage his prostate, to manage and monitor his prostate health?
So I don't know, can they hear that question you just asked? But a patient asked, because his father died of prostate cancer in his 80s, what he can do to manage and monitor his prostate health. That's a great question. This really gets into PSA screening. And anyone who's done any reading on PSA screening of late might have noticed there's been some controversy on that. 10 years ago, we recommended PSA screening for every man over the age of 50 because, in my view, we were over-treating some men with prostate cancer, giving them toxicity when they didn't really need it. And that goes back to maybe we shouldn't treat some of these people. I think the recommendation for PSA screening got softened a little bit. And the current recommendations are that every man should talk to their doctor about PSA screening. So to the person who just asked that question, if your father died of prostate cancer and you're worried about it, definitely have a conversation about PSA screening with your primary care physician. It's very appropriate to ask about that, when it should be done, what the threshold is, how often it should be checked. All those things are important. Besides PSA screening, live a healthy lifestyle. I mean, not just for prostate cancer, but by living a healthy lifestyle, you can decrease your risk of many, many cancers, maybe all cancers. And by healthy lifestyle, I mean exercise. That's beneficial. Keeping it your ideal body weight, very beneficial. Eat a healthy diet. All these things matter. And for people that are predisposed to cancer because of their family history, modifying these lifestyle things really can help a lot. I think some folks are saying obesity is the new smoking. I mean, to me, that's modifiable. If we could just get people to stop smoking and get people to be at their ideal body weight, we would see the cancer rate drop in this country by orders of magnitude. Is that it?
If one's Gleason score is higher than 7 and hormone therapy is required, even after radiation, how long is it necessary, in your opinion, to keep getting hormone shots?
So the question was, if the Gleason score is greater than 7 and hormone therapy is required after radiation, how long should we give these shots? This is a tough question because the answer is we don't know. What we know is that hormone therapy, the hormone shots, help radiation work better. If we give those injections during radiation, the radiation is more effective. That benefit is higher in men with higher risk prostate cancer. So if your Gleason score is 9, you will benefit more from the injections than if your Gleason score is 7. How long should we give those injections? We're not sure. I use risk to help me decide that. So going into treatment, if your Gleason score is 9 and your PSA is 70, I would be inclined to extend the injections for 1 or 2 years, maybe even longer if a man's tolerating them okay. If the Gleason score is actually 7, sometimes we don't even use those injections. There is research going on right now where they're comparing men getting 6 months of hormone treatment to men who are getting more extended courses of hormone treatment. So if I give this talk again in 2 or 3 years, I would expect a better answer about how long to continue those injections, but right now we don't know. So in my practice, what I do is I have a conversation with each patient and we talk about what's your risk, how high is the Gleason score, how high is the PSA, what the biopsy look like. We talk about whether you have heart disease, pre-existing bone weakening that might give us pause in using those hormone therapies. And then we talk about quality of life on hormone therapies. There's really a mixed bag. There are men who get those injections that feel fine. They don't have any toxicities. They have excellent quality of life. And then there's the other end of that spectrum where men who get those injections and they feel awful. They have difficulty functioning. It really impairs, how they live every day. And so I guess this is a long-winded way of saying that I individualize that decision.
How long do hot flashes last even after one stops hormone therapy?
So the reason that you get hot flashes with hormone therapy is because the testosterone is suppressed. And those hot flashes are likely to continue until the testosterone comes back up to a normal or near normal level. And that varies a lot. So if you take men that are getting those injections like Lupron and you measure their testosterone once a month, what you're going to see is that it stays low, and then you stop the Lupron injections. A month later, the testosterone will still be low. A month later, most of the time it's still low. 3 months after you stop, it'll still be low. And then it'll start to go back up and recover. And that varies from patient to patient. So some men will have recovery of testosterone after 2 or 3 months. Some men, it can take 7 or 8 months. Some men even longer. And I would expect a man to have hot flashes until that testosterone level recovers. If you're seeing a doctor, after you're done with the injections, they can check your testosterone and see whether it's coming up or not and give you a better idea of what's going on. But I'll tell you, whether or not you're having hot flashes is a pretty good surrogate of what your testosterone level is. If you're still having hot flashes, it's probably because your testosterone is still suppressed.
I think last question had to do with a gentleman who had a radical prostatectomy and had some urinary incontinence. And so I don't know if you have any suggestions on how to manage those side effects that come with that.
So the question is, someone had a radical prostatectomy and is still having some incontinence. When we talk about cancer treatment, when a man has been diagnosed with prostate cancer and we're talking about options, prostatectomy is an option we talk about. And I'd say there's lots of things that can happen with a prostatectomy, but the two toxicities or side effects that most men are most concerned about are sexual dysfunction and incontinence. It really varies. The best surgeons on earth will still have men who have some level of incontinence or some level of sexual dysfunction after prostatectomy. There's no surgeon who has zero. It varies. I'd say most men don't have debilitating incontinence after a radical prostatectomy. If it's really bad, that's unusual. Most of the time, it's not that bad. Most of patients I care for who've had a radical prostatectomy don't have severe incontinence. I still see it. There are exceptions to this, but we still see it. If it's really bad and you're using multiple pads and it's hard to engage socially because of the incontinence, there are things that a urologist can do. There's procedures that they could look at. There's ways that they could try to help you. So if it's really bad, I would talk to a urologist about some of those things. Short of that, if it's not that bad, cut down on caffeine. If you drink beer, it's going to be worse. Don't have a lot to drink right before you go to bed, those sorts of things. Lifestyle modifications, I'd say those are more appropriate for people who aren't having bad incontinence, where it's just a nuisance. But if it's really bad and it's really impairing your quality of life, I think you owe it to yourself to talk to your urologist. And if you don't like that opinion, I'd get a second opinion. Well, thanks for tuning in, and we'll have more Facebook Live programs coming up in the next few weeks and months.